I'm Ramaswamy Govindan, a professor of medicine at the Washington University School of Medicine in St. Louis. One common question we get asked is that what is the optimal chemotherapy regimen, the backbone chemotherapy regimen for patients with locally advanced stage 3 unresectable non-small cell lung cancer? This is an important question. The reason is that um, this is a common problem. Nearly a third of our patients with lung cancer have locally advanced disease, and we do have a variety of treatment options. So let's just go back and look at the historical data. In the early days when chemotherapy and radiation regimens were combined either in sequential fashion or concurrent fashion, the dominant theme in those days, in the late 80s, 90s, and even in the early 2000s, was often to use cisplatin and one other agent in systemic doses. For example, cisplatin and blastin to begin with in the old induction chemotherapy, followed by radiation regimens. And then with concurrent chemo radiation regimens, various different combinations were explored. And then around the, I would say, early 2000s, we really got used to this weekly regimen of paclitaxel carboplatin. And this was given at a much lower dose than systemically active doses. For example, paclitaxel 50 milligram per meter square with carboplatin UCF2 on a weekly basis for 6 weeks, along with radiation. So in 2000s, from 2000 to maybe 2000, mid 2015, several different of these regimens were explored. On the lower dose regimen, this is the weekly paclitaxel carboplatin I just mentioned. And systemically active doses, one regimen really supported by many of the Southwest Oncology group, the SWOG studies, where cisplatin etoposide, where cisplatin is given on day 1 and etoposide on day 1 to 3 or day 1 to 5. And in these regimens are given every 28 days, and they were also explored and for quite some time. And I would say the cisplatin etoposide regimen was probably tested the most, at least in the US setting, along with radiation, and that was given at systemically active doses. In other words, they by themselves, they were active regimen even without radiation, modestly so, but nevertheless active. And I, for a long time, thought this is cisplatin or etoposide given in systemically active doses probably was the way to go. And in fact, that used to be our preferred regimen. Then we and others did studies using pemetrexed with platinum agent, both the cisplatin and carboplatin in systemically active doses. And one thing was striking, and the results were almost identical, even though the cross-trial comparisons were are not ideal to do. But the outcomes we got in all these treatment regimens, in terms of overall survival, was not that different. And then we did a head-to-head study comparing cisplatin, pemetrexed with a variety of other regimens, and it didn't really show to be. We couldn't show that cisplatin, pemetrexed was any superior to the other regimens. But what really brought home all these data, at least to me, was this RTOG study led by Dr. Jeff Bradley, my former colleague in St. Louis. This was published in Lancet Oncology a few years ago, which really tested the conventional dose radiation regimen with high dose regimen and the treatment, high dose radiation regimen, and the treatment, chemotherapy treatment there was paclitaxel carboplatin on a weekly dose, and that probably produced one of the best results we've ever seen in the conventional radiation therapy arm. And so that gave me reassurance in a large randomized study, even though the question was not the chemotherapy question. In the control arm, paclitaxel carboplatin weekly gave as good a results as we've ever seen. And of course, all these things have been overshadowed today by the consolidation durvalumab. And so I would say with all these things, weekly paclitaxel carboplatin is well tolerated. And I think these kinds of modest doses of radiation, modest doses of chemotherapy augment the radiation's effect. And this kinds of a combination regimen would be ideal. So I practice, in my own practice, I only give paclitaxel carboplatin on a weekly basis along with radiation treatment. We have shown before that the induction chemotherapy did not make a difference, so we don't give any induction chemotherapy. Consolidation docetaxel initially was viewed with some optimism, but later on in randomized studies, we showed that, I should say in a randomized study, we showed that consolidation docetaxel actually produced worse outcomes. So giving consolidation chemotherapy is not a good idea. And after chemoradiation, weekly paclitaxel carboplatin, I go straight to durvalumab in the consolidation or the maintenance setting.